historically what we've done is we've referred to patients with PFO-related strokes. We've called them cryptogenic stroke with PFO, which is kind of stupid.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 153 of the Strokecast. If you have a hole in your heart, should you get it fixed? This week's episode is brought to you by the fine folks at Modus Nova. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. And by the fine folks at Like Minded. To find out if Like Minded can help you live your best post-stroke life, visit strokecast.com/Like Minded. I'm joined today by Dr. David Thaler, the neurologist in chief at Tufts University Medical Center, to talk about his research on whether or not you should close a PFO. Now, before we get into the conversation, let's talk about what a PFO is. A PFO is a hole in the heart. Roughly 25% of the population has one. I have one. Several of our guests have had one. Misha Montana and Christine Lee have both had PFOs that led to their strokes. You see, after we're born, our blood flows through a specific path through the heart. It comes in the right side of the heart, and when the heart beats, the blood on the right side then heads out of the heart and to the lungs. When it gets to the lungs, it drops off CO2, it picks up oxygen, it filters out clots, and then it heads to the left side of the heart. It will pour into the left side, and when the heart beats, it sends that oxygen-rich blood onto the brain and all of the other parts of the body. When the blood gets where it's going, it drops off its oxygen, it picks up CO2, and it heads back to the right side of the heart to start the whole cycle over again. But before we're born, the process is a little bit different. While we're developing in our mother's uterus, we don't breathe air, of course. All the oxygen and nutrients that we need to build fingers and toes and kidneys and hearts and brains and everything else, it all comes from the umbilical cord. Since we're not breathing air, there's no point in sending blood to the lungs while they're still developing. Instead, in utero, the blood goes straight from the right side of the heart to the left side of the heart through an opening in the middle. That hole in the middle of the heart is called a patent foramen ovale, or a PFO. Now, it normally closes on its own shortly after we're born, but a quarter of the time, that doesn't happen, and it doesn't close. And that allows unoxygenated, unfiltered blood to sneak across the heart, skip the lungs, and drag a blood clot to the brain or really anywhere else in the body. So, if you've had a stroke and you have a PFO or a hole between the right and left side of the heart, should you have surgery to close that hole? Maybe. Christine and Misha had their PFOs closed. I did not. Dr. Thaler's research helps doctors make the best recommendations for their patients to close the PFO or not to close the PFO. So now, let's meet Dr. David Thaler.
So David, thank you so much for joining us on the show this week.
Thank you for having me.
Now, I really wanted to talk with you because you've been involved in some research and looking at exactly when we should be doing heart surgery and closing PFOs. So I guess to start off, what is the latest estimate on the prevalence of PFOs?
So that hasn't actually changed very much. PFO was first identified in the 16th century by an Italian who didn't know what it was, but since then we've become much better acquainted with them. If you looked for a PFO, which is not the easiest thing to look for in most people, so it's not something that comes up on regular screening kinds of tests or a physical exam, but if you look for them in just regular people walking around out there, typically what I tell patients is 1 in 4 people have a patent foramen ovale in the general population, or something like 2 billion PFOs walking around out there in the world.
It's kind of amazing to think about that scale. I remember when they looked for mine, I was in the ER that fateful day, and they're doing the ultrasound, and then she goes ahead and injects air into my system to do the bubble test. And I'm like, every time I see this on NCIS or Criminal Minds, it's when they're actually sneaking into a hospital room to kill somebody.
Air is in fact being injected, but remember, it's agitated with saline and a little bit of blood. And so what you're really injecting are microbubbles, which are really teeny tiny. That's issue number one. Issue number two is it's not very much air. If you injected a whole bunch of air, yeah, that could really cause trouble. The purpose of injecting microbubbles into a vein is that it serves as a contrast medium. It's something that you can actually see. So when you're doing an ultrasound of the heart, or listening to the head for that matter, but let's stick with the heart. If you're doing an ultrasound of the heart and you inject bubbles, you see them on the ultrasound arriving on the right side of the heart. That's just the normal circulation. And typically they would then end up in the lungs and get sucked up and disappear, and you never notice them. But on the ultrasound, if you see them show up on the left side of the heart, that means they would have bypassed the filtering of the lungs. And the only way that could happen is if they go directly from the right side to the left side of the heart, or that's the most common way anyway. Yeah, little tiny bubbles is how we decide whether there's a shunt between the right side of the heart and the left side of the heart. Almost never does it cause any trouble. There was one small paper that suggested some people might get migraines or transient events of some sort, but I don't think I've ever seen that personally, which isn't a great way to practice medicine to say just because I haven't seen it, it doesn't exist. But it's exceedingly uncommon, and it's a very safe technique. So don't worry about bubbles.
And pro tip, if you do happen to be an assassin, you have to use a lot more air to cause a problem.
You have to use a lot. Yeah, that's true.
And I got to say, if you're experiencing migraines or another transient event at that point in time, it's probably pretty low on the list if you're already in the ER for stroke treatment and they're trying to isolate those other things. You've got higher priorities to be concerned about.
Yeah, I think that's fair.
What percentage of strokes are currently thought to be caused by a PFO?
Yeah, another good question. And it's a bit of a moving target, but if you think of it this way, and what I'm about to say isn't perfect, but it sort of gives you a way to think about it. How do we know what causes any stroke? I guess that's the first question. If somebody has atrial fibrillation, an irregular heart rhythm, which is associated with blood clots forming in the left side of the heart and then embolizing into the brain. So we find someone with a stroke and with AFib, and we say, oh yeah, it's probably the AFib. We don't know for sure it's the AFib unless we happen to see a bunch of clot in the heart, which is pretty uncommon. But we kind of presume it's AFib. So it's sort of a probabilistic conclusion. It's such a powerful stroke mechanism that you see AFib and you say, okay, this is an AFib-related stroke. Or we see a high-grade carotid stenosis on the same side as the stroke, and we say, okay, this was an artery-to-artery embolism, and so forth. So there are different definitions for different stroke mechanisms, and some are more specific than others, but the bottom line is we think we have a pretty good understanding of most individual stroke patients' mechanism based on these definitions of AFib and large artery disease and small artery disease and various other things. And then you're left with this category that we have in the past referred to as cryptogenic stroke. Crypto means hidden, and genesis is source. So a stroke of a hidden source. So stroke without AFib and without carotid narrowing and without all the other things that we think we can explain. And then you're stuck with someone who definitely had a stroke, but we can't say exactly why it happened. So that used to be called cryptogenic stroke. Some people now are referring to it as ESIS, or embolic stroke of undetermined source. The definitions vary a little bit, but it's within that category of cryptogenic stroke patients that most of the interest of PFO has laid. And that's because we know PFO causes strokes, we think. We think we understand how it happens. And then when you look for PFOs in the cryptogenic stroke population, it's not just 25% like in the general population. We find about 50% of the cryptogenic stroke population have PFOs. PFOs are way overrepresented in cryptogenic stroke patients, which means that there probably is a relationship between the PFO and ending up as a cryptogenic stroke patient, and that's because PFOs can cause strokes, we think. So what are the proportions of stroke patients like that? So it's roughly 30% or so. It changes a little bit by age, but roughly 30% or so of the whole stroke world have officially a cryptogenic stroke or an embolic stroke of undetermined source, and about half of them will be found to have PFOs. So we're now down to about 15%, I guess, of all of the stroke patients. In those patients who have cryptogenic stroke and in whom a PFO is found, that's not the same thing as deciding that the PFO caused the stroke, because stroke is so frustratingly common in the general population. There's another trick that we have to get to decide whether it was PFO related or not. But about half of the discovered PFOs are likely to be related to the stroke. So that gets you down to about 7.5% roughly of all of the strokes that occur. So, it's pretty common, and it occurs in younger patients very commonly. I don't think it stops occurring as people get older, even though people think of it as a young stroke patient mechanism. I think it occurs in older people too. And in fact, it might even become more common as we get older, but because strokes as a whole become more common because of other things that we can identify like AFib and whatnot, the cryptogenic stroke proportion of older patients is lower. It's generally thought of as a young stroke mechanism, but I think it occurs in older people as well. And it's on the order of like 5 to 10%, I think, of all strokes, something like that.
There's a lot there to unpack. I think when you're talking about with older folks, I think one way to think about that is that as you get older, there are other causes of stroke that are likely to be causing your stroke, which probably doesn't decrease the likelihood of a PFO-related stroke, but just means that there are a lot of other reasons why you're likely to have a stroke too, which will offset that percentage then.
Yeah, exactly. I mean, if you think about it, the prevalence of stroke in 30s and 40s and 50s is on the order of 100 per 100,000 people, or maybe up to 200 or 300, kind of depending on which decade you're looking at, stroke patients per 100,000 people in the general population. But when you get into the 60s and 70s and 80s and 90s, the prevalence of stroke shoots way up to like 1,000 or 2,000 or 3,000 per 100,000 people, which is a huge number. And why is it shooting up? It's shooting up because people get heart attacks, people get atherosclerosis, they get much more cancer and hypercoagulability and so on and so on. So the stroke prevalence amongst just people goes way, way up. And there are lots and lots of new stroke mechanisms that occur as we get older that you're almost guaranteed not to have when you're younger. So, there's not going to be a 25-year-old stroke patient who has carotid atherosclerosis. That's just almost inconceivable. But they can have dissections, and they can have PFOs and meningitis and other causes of stroke. And dissections and PFOs and meningitis don't go away on your 60th birthday or your 61st birthday, I guess. But there's so many other stroke mechanisms as people get older that they seem to be less of a concern as people get older. But I think they, particularly with PFOs might even become increasingly important as we get older from the perspective of their own individual risk.
And that makes sense. I think the other thing to keep in mind too is that even when we're talking about PFO-related strokes, a PFO doesn't necessarily cause a stroke as much as a PFO allows a stroke to happen. It still requires that a clot sneaks through that PFO to get to the brain to cause the issue. And there's still something else causing that clot.
Yeah, absolutely. Although it's an interesting question about whether a small thrombus or clot arriving in the right atrium is necessarily abnormal. So you can't see me because this is a podcast, but my legs are crossed right now. And I wouldn't be at all surprised if I'm generating a 1 or 2 millimeter superficial venous thrombus, not a DVT, but just a little thrombus somewhere in my body. I think it might leave my little vein and end up in my right atrium, but almost never is that important because it goes to the lungs and gets absorbed and is never noticed. And, if you twist your ankle and get a big bruise, or you cut yourself and you get a blood clot, in your skin and then a scab and all that, there could be little tiny thrombi generated from all of those things too. So I don't know that thrombus arriving in the right atrium is necessarily abnormal. It's a little bit hard to get to the answer to that question, but I don't know that it's abnormal. The abnormality with PFO, as you pointed out, is that the thrombus has access. It has a back door around the filtering effect of the lungs and is allowed to jump into the left atrium, and then from there it can go wherever it likes. And keep in mind, these little thrombi, once they arrive in the left atrium, they don't only go to the head. They could go to your finger or your liver or your butt, and you would never notice it. The reason that PFOs are related to strokes is that it's only the brain and the eye and occasionally other tissues which are incredibly, exquisitely sensitive to tiny areas being affected with blood clots. So that's why it seems to be a brain issue, although these little blood clots probably end up all around the body.
And that's something we don't usually think about. I think a lot of people don't even think that, you talk about generating blood clots all the time. Anytime you have a bruise, that's essentially blood clots underneath the skin.
That is a blood clot. Absolutely. Yeah. And it generally most of it's just going to get absorbed, but I wouldn't be surprised if little pieces of it break off on occasion. We had a patient, by the way, for recipient tissues, my cardiology colleague here and I saw a young man, I think in his 30s, who had a heart attack, an occluded coronary artery. When he had his cardiac cath, his arteries were completely clean. He has no atherosclerosis, no risk factors for it, and he had a PFO. And so he's one of the few people who had a symptomatic embolism through the PFO that ended up somewhere other than in the brain. It ended up in his heart, causing a big heart attack.
Mm-hmm. And I think a lot of people don't realize what's happening in a heart attack is the heart itself is pumping blood throughout the body, but the heart itself is muscle tissue and that it needs its own blood supply to supply nutrients to it. And a heart attack is when the blood vessels feeding the heart muscle itself to keep the heart itself functioning, those get blocked and cause problems.
Exactly right. And that's what happened with that young guy.
So I think one of the other things that's really interesting about a PFO, and I know in my experience with my PFO, they found it in the ER. We went through follow-up tests on it. I got to have my first experience with propofol for a TEE where they stuck an ultrasound down my throat to look at my heart. And that propofol, that was fun stuff. Let me tell you, that was an okay day. But what they found was that I know mine turned out to be relatively small. So they were like, yeah, we don't have to worry about that. But the size of the PFO, the size of that opening between the right and the left makes a difference in terms of how risky it is. Now, I understand that your research is about evaluating a system to decide which patients should have that hole closed up and what's going to be the result of closing that up, because a lot of people think, well, you got a hole in your heart, you should just close it. But at the same time, doing surgery on the heart has its own risks and evaluations. So you've been looking at this. And so, I mean, what was wrong with the previous decision-making criteria about whether or not to close that PFO?
Yeah, so there's a lot there. Really good questions. I alluded to this a second ago. But the first step for an individual patient when they've had a stroke, there's no other explanation for it. So let's say they're in this bucket of cryptogenic stroke, and then a PFO is found. The first question is that part of the background 25% noise of the prevalence of PFO in the general population, or are they the extra 25% of cryptogenic stroke patients where there are too many PFOs and their PFO probably caused their stroke? Is there a way that we can disentangle the incidental from the pathogenic PFO, or the innocent bystander PFO from the one that really committed the crime? I guess that's the first question. And it's that we tried to address with the ROPE score. So ROPE stands for risk of paradoxical embolism. Paradoxical embolism is the term for a venous source blood clot that jumps across and paradoxically appears in the arterial side, which can only happen if there's a right to left connection. So the risk of paradoxical embolism, or ROPE score, was something that I did together with a colleague who's much smarter than I am in scientific methods and techniques and so forth, and predictive modeling. And we came up with an 11-point score from 0 to 10 that separates cryptogenic stroke patients into buckets where they're more or less likely to have a incidental or pathogenic PFO. So what do I mean? If every stroke patient who comes in is a certain age, they're 20 or 30 or 42 or whatever, every patient who comes in either has or has not had a history of hypertension, a history of diabetes, a history of smoking, and something about the appearance of the stroke on the scan and so forth. And it's those simple variables that separates people into ROPE scores of 0, 1, 2, 3, or up to 10. And it turns out that if your ROPE score is 8, 9, or 10, so those are the highest ROPE scores, those are the youngest patients without vascular risk factors, the prevalence of PFO, or the likelihood of finding a PFO in people with a ROPE score of 8, 9, or 10 is way too high. It's 70-something%, not just 25%, not 50% like in all of the cryptogenic stroke patients, but it's way up to 70-something%. And using some math and some other assumptions, it turns out that the likelihood that those PFOs that you discover in a ROPE score, in a patient who has a ROPE score of 8, 9, or 10, those PFOs are about 90% likely to have been causally related to the stroke. So the ROPE score that we published several years ago now gets you to a closer handle on whether that patient's PFO was causally related to the stroke or just part of the background noise. What the ROPE score didn't have in it was anything about the discovered PFO itself. So as you noted, there are large ones, PFOs, and small PFOs. And then there are other anatomical characteristics like the size of the opening, not just the size of the shunt, how much blood is getting through, but the physical size of the opening, or even how floppy is the wall that separates the right atrium and the left atrium where the PFO is sitting, because that too has some bearing on the risk of stroke and its recurrence. So the ROPE score gets us to whether the PFO was likely to be related to the stroke or not, but it didn't help us because from the perspective of, is this PFO a particularly risky or less risky one? Recently, I think what you're referring to is we looked at all of the 6 randomized trials that were just done. We had all of the individual patient data from all of the trials sent to us by all the trials. So we mashed up all the trials together into one big database of almost 3,000 patients or so. And then we had a good data set where we could test this theory, which is if somebody has a high ROPE score and therefore their PFO is more likely to have been causally related to their original stroke, if you close that as opposed to don't close it and continue taking medicine like aspirin or whatever, you might expect that the benefit from the perspective of reduction in risk of recurrent stroke or having a second stroke, the benefit would be higher in somebody who had a high ROPE score as opposed to somebody who had a low ROPE score. So if you're 70 years old and you have hypertension, diabetes, you have a PFO discovered. You don't have any other clear explanation for it, but still it's less likely to be PFO related in that person. Closing that PFO is less likely to be beneficial from the perspective of stroke prevention. With the 6 randomized trials, we were able to show that hypothesis was well supported. In other words, if you have a high rope score, you're more likely to benefit from the perspective of PFO closure than if you have a low rope score. What we then did was we added on top of the rope score the PFO characteristics for the individual patients. So some patients had a high rope score and a really big shunt. Some patients had a high rope score and a really small shunt. Some people had a floppy septum or wall between the 2 atria, and some people had a really stiff one. And we were able to, for the individual patients, categorize them into probable, possible, and unlikely, based on the combination of the rope score and whether they had any or none of those 2 PFO characteristics that I just described that you can only see on the echo. And when we did that, it turns out that those with probable and possible PFO-related strokes, as opposed to innocent bystander PFOs, the treatment effect was enormous, much higher than the average result in the general population in the trial. And for those who had unlikely PFO-related strokes, even though they were in the clinical trials, their benefit was not measurable. It doesn't mean that for some individual patients it's nevertheless helpful, but this allows us to better risk stratify the patients to those who have a very high benefit and a very low benefit. And importantly, and this is the last thing I'll say, and then I'll let you ask another question.
Yeah.
Importantly, from the perspective of the risk of the procedure, and generally we call it a procedure rather than surgery. It's all catheter-based from the groin kind of thing rather than opening up the chest. So, but the risk of the procedure resides almost entirely in those who have the unlikely PFOs and some of the possibles, but very few risks were seen to have occurred from the procedure in the probable category. So bottom line is it allows us to separate patients into probable, possible, and unlikely PFO-associated index strokes, and those with the highest likelihood of having the PFO-related stroke had the greatest benefit and almost no risk, and then it flips a little bit for the lower likelihood patients. So that's the advance that we have seen from the analysis of the 6 randomized trials that was published just a few weeks ago.
Gotcha. Okay, so there's a lot I want to unpack there. But first, a quick question here, though. When we're talking about, are you seeing any difference in the risk of a post-stroke PFO closure through that procedure, going through the vessels in the groin, with someone who has also gone through a mechanical thrombectomy, or versus someone who hasn't gone through a mechanical thrombectomy? Since in mechanical thrombectomy, we're typically going through the same route, the same blood vessels through the groin, up through the body, only instead of going into the heart, we're going into the brain to drag out the clot. I wonder if that second entry through there causes any further issues.
Really interesting question based on an inaccurate premise. And what I mean, you're right, it's the groin, but there are different vessels in the groin. So when you're going up to the brain to do a mechanical thrombectomy, you go into the femoral artery. That's an artery in the leg, and the catheter goes backwards against the flow of blood through the aorta, and then finally goes up into the carotid or the vertebral artery and makes it up into the head. So that's an arterial puncture. When we do PFO closure, it's done through the femoral vein, the blood that's going back to the heart, and you track along the direction of the flow that's going up into the heart with the catheter. And you put the device from the right side of the heart, from the venous side, across the PFO, deploy it, and pull the catheter back out. So mechanical thrombectomy is done through the arteries, also access through the groin, but the PFO closures are done through the veins.
That makes a lot of sense. Always like starting with incorrect premises because that and then teasing those apart, the further analyses. So what we're finding is that if somebody has a high rope score, they are much more likely to have a PFO than the general population. If somebody has a high rope score, an 8, 9, or 10, as opposed to somebody who has a low rope score of maybe a 1 or a 2, if you close the PFO in the 1 or a 2 versus the 8, 9, or 10, it's probably not going to impact recurrent stroke in the 1 or 2 the way it massively impacts the rope score. It massively impacts the likelihood of a second stroke in the 8, 9, or 10. And then taking that further, we apply this additional analysis of what type of PFO, how big is it, how much blood is flowing through, how floppy and turbulent is that flow. The more turbulent, the more shunting, the more blood flow through there, the more likely it is to be involved, and therefore closing the PFO under those conditions is much more likely to prevent recurrent stroke as well.
Yeah, I think that's basically right. I just want to clarify.
Absolutely.
The beginning of all that, which was if you have a high rope score, you're more likely to have a PFO. In the general population, that's not what we tested. What we tested with the rope score is the likelihood that the PFO caused the stroke within a stroke population. So the rope score is only meant to be applied to stroke patients in whom a PFO has been found to decide whether that PFO is more or less likely to have been causally related to the original stroke. I can't do a rope score on, everybody walking across Boston Common right now and say, you've got a PFO, you don't. You can't, so it doesn't apply that way. But otherwise, I think I agree with everything else you said. The rope score gets you some way towards identifying those who particularly benefit from PFO closure. But when we add these other two variables and then reclassify patients, not just probable, possible, and unlikely scheme, which is called Pascal, by the way, it seems to be particularly helpful at identifying patients who are likely to benefit and also identify patients who are more likely to be harmed by the procedure.
Gotcha. Okay, that makes a lot of sense. So you mentioned you can't just obviously just start doing the rope score on folks walking across Boston Common. In general, should doctors or physicians or ultrasound technicians be screening for PFOs in patients who haven't experienced a stroke?
Yeah, not yet. And I say that because remember, you're going to find one in 4 of those people will have a PFO. And then you're going to have to figure out what to do with them, number one. Number two, all of the studies and all of the research that we've done and that I've been describing comes from stroke patients, not from people who happen to have PFOs, but from people who have turned themselves in, unfortunately, to stroke patients. And it's in those people that we think there's a reasonably high enough risk of recurrent stroke that it's worth undergoing some kind of procedure. All of the data have been about secondary prevention of stroke, which refers to preventing a recurrence after one has already occurred. You're implying that there might be reason to consider treating for primary prevention. That means preventing the first stroke. That's what we're doing when we treat blood pressure in a 40-year-old who's just getting screened by their primary care doctor and their pressure's 150/90. Why do we give them pills to lower their blood pressure? That's for primary stroke and heart attack and other things, but primary prevention, preventing the first episode. Everything we've been talking about so far has been about secondary prevention. Now, I have actually an interest in wondering about whether there is a population who might be at a strangely or peculiarly high risk of having a first PFO-related stroke, and maybe it's worth screening in those kinds of populations. And there might be something to that, but we're not there yet.
So with this research and with this looking at these additional factors, I mean, what should clinicians be doing with this data now?
So the first thing is that historically what we've done is we've referred to patients with PFO-related strokes. We've called them cryptogenic stroke with PFO, which is kind of stupid because it's saying it's we don't know why it is, but it's from the PFO. Nobody would say it's cryptogenic with a 90% carotid stenosis. That just sounds stupid. At some point, you have to just say, yeah, no, we get it. We understand it. This is how we're going to define PFO-associated stroke. We're going to stop saying we don't know why it happened, but anyway, they got a PFO, so maybe it's the PFO. We're better than that now, I think, with the rope score and the new Pascal algorithm. So the first step is to embrace the idea that we can actually make a diagnosis and say it's all probabilistic, but still say, I think this is a PFO-associated stroke. So that's number one. And, the epidemiology is a little bit different. It gives patients some sense of, what actually happened rather than everybody shrugging their shoulders and saying, I don't know, it might be the PFO. It doesn't have to be.
That shoulder shrug is very disconcerting.
Yeah, you're right. And, I don't want to give people false information and false confidence on our part, but I think what we can do now is probabilistically estimate this is a 90% likelihood that it was due to your PFO or not, rather than, I don't know, which is what we have done historically. So I think the first step is to embrace this concept of a PFO-associated stroke. That's number one. Number two, I think there's going to be homework that the echocardiographers need to do and embrace, because the Pascal algorithm, which relies on observations about the nature of the PFO itself from the echo, those data were derived from clinical trials where we were carefully observing the PFO and what kind it was and so forth to see if there was any relationship between recurrence and whatnot. I can tell you just by reading a million echo reports on a million patients I've seen, the echo says the valves are this, the aorta looks like that. There is a PFO. That's what it says. Or bubbles were seen or something like that. And there isn't any indication that it's a large shunt or a small shunt, or that there's a floppy septum or not a floppy septum. And even worse, there isn't great consensus on what are the definitions for large and small shunt and floppy or tight septum. So the echo people need to work with those of us interested in PFO to help us understand our individual patients and where they fit on those two variables. And so that's going to need a widespread effort to get the variables defined, and importantly, have some comment about them end up in the echo reports so that we can classify them appropriately. I mean, I'm a neurologist, but I look at my own patients' cardiac echoes only because they're not reported in the way that I think I would find most useful. That's the second thing. And then the third thing is to make sure that patients are investigated for PFO, then refer patients who have a stroke of unknown cause or a stroke that you think is PFO related to be seen by a neurologist who works together with a cardiologist to decide whether closure is appropriate. When the FDA approved the two devices that are currently available on the market for approval, they did an unusual thing in the letter, which said that in the indications for use, which says that PFO closure is indicated for people of a certain population, blah, 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 and who have been evaluated both by a neurologist and a cardiologist. I think that's a message to neurology to make sure that closure can be achieved from a technical perspective. But also importantly, it's a message to cardiologists not to try to make stroke diagnoses and refer patients to neurologists to make sure that it is a PFO-related stroke and not some other another stroke mechanism which has nothing to do with PFO.
And I think that's really important. First of all, I think it is utterly delightful that there is a medical criteria of floppy. That just amuses me to no end. secondly, I think one of the things that often gets overlooked, like say, with you're having these conversations that have to happen with neurologists and cardiologists. I think even in the general population, we think of stroke, and most people think of it as it's just about brain tissue. It's just about the nerve cells and the neurons, and often that's what we talk about. But really, stroke is a blood vessel born condition, and it is so intrinsically tied to that. I mean, that even our official name for stroke of CVA, a cerebrovascular accident, the vascular part is right there. And I think it often gets overlooked, even though we're always talking about hemorrhages or clots.
Yeah, so I've got to interrupt. CVA is a term that no stroke doctors use and derisively dismiss it as confused vascular analysis. So it's not a term that I ever use, but I will completely agree with you that stroke is not – I would rephrase what you just said and say that stroke is not a disease. It's the endpoint of many other conditions. Stroke neurologists are working very closely with hematologists for hypercoagulable patients, oncologists for patients who have hypercoagulability, vascular surgeons for carotids and vertebrals, cardiologists for PFO and atrial fibrillation, primary care doctors on anticoagulation issues. So there is just about every specialty can touch on or end up having strokes occur in them. So it's not one problem, and I think you're right. People often think of a stroke as a stroke, but to a stroke doctor, we try and identify the mechanism for that patient's stroke because, first of all, we need to treat that patient, and if it's cancer causing their stroke, we don't want to miss that. But importantly, the prevention of a next stroke depends hugely on identifying the cause of the first one.
By extension, then, I suppose one way to think about it then is that stroke is a symptom rather of another disease, and a rather severe symptom at that.
Yeah, I think that's fine. It's an endpoint. It's a complication of a disease. Hypertension is a risk factor for stroke. It usually doesn't cause it directly. It causes blood vessel diseases, and then something happens. So, yeah, it's the endpoint of a bunch of other problems.
With this new research and this analysis, what we talked about what clinicians should be doing with it. What about survivors? What should the survivor community be taking away from this research?
Yeah, that's a great question. And one thing that I try and encourage my patients, in whom I think PFO was the explanation, is to not get on the internet and type in, what's the chance of having another stroke after you've had a stroke? The problem with that search is based on what I just said, which is stroke is not a disease. And if you're 25 years old with a PFO-associated stroke, your risk of recurrence is probably about 1% per year, maybe. I mean, that's higher than nothing, but it's not the same as an 85-year-old hypertensive, obese, alcoholic, diabetic smoker who's had a stroke. Their risk of stroke is maybe more like 1 in 3 in the next year. And so the first thing I'd say for patients who've had PFO-associated strokes is congratulations, because this is a very low-risk stroke mechanism. It's not that it can't recur, and we spent a lot of time talking today and thinking for years about how to prevent recurrences, but it's a much less risky circumstance than many other stroke circumstances. That's the first thing. The second thing is there is time to think about PFO closure or not. It's not usually an emergency for secondary stroke prevention. So take your time, find a neurologist who's knowledgeable and you can trust, and a cardiologist that that person trusts, and then decide if you want to proceed. Because importantly, shared decision making is this is a prime example of where you need shared decision making, because a lot of this is probabilistic. If I tell somebody that their PFO is a 60% likelihood of having caused their stroke, and they're not a probable PFO, but a possible PFO-related stroke where the treatment effect is still greater with PFO closure than taking medicines, but not as great as if it was probable PFO, then they might decide themselves that they don't want to have something put in their heart. The procedure is very low risk, but it's not no risk, and patients need to engage and understand it as well as we can help them to understand it, and then they need to help us decide whether it's something they want to pursue.
So ultimately, it's about understanding your risks, your risk tolerance, and the conversations and partnerships you're able to have with your medical team as you build the team that's going to be right for your particular experience.
Yeah,
so,
absolutely.
So why did you want, what really spurred your interest in PFO research to begin with?
That's a good question. It was a frustrating problem to see a 30-year-old patient who had a stroke, look them up and down for regular causes of stroke, and they don't have anything, and then we find a PFO, and we didn't know what to do because there was no way of disentangling like I was saying before, the background PFOs from the ones that really cause trouble. The only way you really know that the PFO caused the stroke, the only way you get to a definite PFO-related stroke is if you see a blood clot straddling the hole, right? So, a crayon-sized thrombus crossed on the right side and on the left side, just flopping around, and somebody's had a stroke and you assume a little piece of it is broken off. I've never seen that in my clinical practice. I've seen about 3 or 4 pictures of it in the literature, and it's always the same few pictures that you see at conferences. So I don't think it happens very often, but it's definitely happened. But apart from that, you're just kind of stuck with, not knowing really what is the whether it's a bad one or a friendly one is the first question. And then, closing it made sense, but we didn't know that closing it helped until we did the study. So I've not only been involved in this rope score and Pascal and trying to figure out which are the bad ones and which are the not so bad ones, but also in some of the clinical trials to demonstrate that PFO closure actually helps. There were very long trials, and we're very grateful to the patients who stuck with us for, in some cases, over a decade. They were participating in the follow-up to answer this question. But now I've finished medical school in, I'm looking up at my diploma, 92, and neurology residency and fellowship after that. And so for 20-something years, I've been trying to help to answer this frustrating question for these young stroke patients. And fortunately, I think we've made some headway. It really just started with the frustration of not knowing what to do with people who are looking at us to answer their questions, which is, how risky is this? And what do I do to make it go away?
Well, that's amazing. And we have come so far over the last 20 years or so. But like I said, you've been doing this since 92 then, getting in neurology. I mean, what's been most rewarding about being in neurology? I mean, why did you get into neurology to begin with?
Well, I went to medical school after I finished college, obviously, but also my PhD, which was in neuroscience. So I was a neuroscientist who went to medical school rather than just a regular college guy who went to medical school and then turned into a neurologist. So it was sort of it was in me anyway. And so it just seemed to make sense for a neuroscientist to become a neurologist rather than a plastic surgeon. So I sort of just fell into it. And, but to the question of, what has it been like, it's not that long ago, but even when I started, the reputation of neurology was that it was a very cerebral, I know it's kind of funny because it's a brain thing, but it was a very cerebral specialty where doctors would sit in a chair and scratch their chins and opine, but not have anything to do for patients. So diagnose and adios is what the sort of reputation had been, which was already unfair. I knew that was not the case. But the change in my already relatively short career, 20 years or so, has been amazing for stroke treatment. I mean, now we have IV TPA and mechanical thrombectomies to pull blood clots out of the head. And stroke is just not the same thing now as it was just a few years ago. If you get a big MCA occlusion, the big main artery supplying a third of the cerebral hemisphere, we can go take it out, and sometimes people go home the next day with essentially no deficit. That just was unheard of just a few years ago. That's been amazing to watch. And then the strides that we've made now in this not small population of young stroke patients has also been very gratifying. Now I don't have to have a 40-minute conversation about, well, it could be this, it could be that. I know how to talk to PFO patients now because we have data that can inform what I tell them. I mean, if you go to your primary care doctor with a sore throat, they don't have to talk to you for half an hour about how antibiotics work. And sometimes the streptococcus, which looks like this, it breaks down the bacterial wall. You don't need that. You just say, okay, yeah, give me this stupid antibiotics and let me go home. It's hopefully going to become more like that with more stroke mechanisms, that we just say, oh yeah, we know how to treat this. This is what we do, and this is what I recommend. So it's been rewarding from that perspective too.
Well, it's fascinating to watch all this evolve, and for you to have the chance to pursue this and be a part of this evolution as part of your career. And I know those of us on the survivor side absolutely are very appreciative of all the work that has gone into the research and into the new mechanisms. So, I mean, David, if folks want to know more about you and what you're up to, where should they go?
Well, I'm pretty easy to find, although there was a paper written by David S. Thaler. I'm David E. Thaler, who's some Swiss scientist. And somebody forwarded me the news article about it because my picture was there. Somebody Googled David Thaler and ended up with the wrong one and put my picture there.
Well, I hope he's doing good research too then.
Right. Well, actually, it was funny. I'm not entirely sure I agreed with it. But so if you just Google David Thaler, Thaler, and Tufts Medical Center, or just Tufts, you'll find us. And actually, I'll put a plug in for our art exhibit here in our department, which is called Neurology Illustrated, which has neurologically relevant pieces of art with art history and neurology thrown in. So if you want to look at Neurology Illustrated Tufts, you'll find our exhibit, some of which talks about vascular disease, but lots of other neurology stuff too. It's fun.
Fantastic, and we'll definitely link to that in the show notes as well. Oh, great!
Thank you.
As well. So, David, this has been fascinating. I've learned a lot. I've had some of my assumptions questions, which is awesome. I love it when that happens, and I learn stuff. Thank you so much for joining us today. This has been great.
Oh, it's really nice of you to be interested, and I enjoyed it.
And that brings us to our hack of the week. But first, let's talk about sponsor Modus Nova. Modus Nova helps brain injury survivors recover the use of an affected limb with the power of neuroplasticity and repetition. And video games. The Modus Hand is an air-powered, AI-controlled robotic exoskeleton. It helps you move your hand to complete actions in the video games you play on the included touchscreen monitor. Recovering an affected hand or foot, of course, requires thousands of repetitions of that motion. You have to keep repeating it over and over and over again to really leverage the power of neuroplasticity to reshape the brain. The Modus Hand and the Modus Foot help you do that without getting bored. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. Use promo code STROKECAST for 10% off your first month. And now back to our hack of the week. This week's hack actually comes to us from stroke survivor Kawan Glover. Now, I talked with Kawan in the previous episode. You can hear that full conversation at strokecast.com/Kawan.
I find that it's very beneficial to take 10 seconds to just plan out how you're going to do the task in front of you. So like if I'm going to put away the dishes, hey, I'll stop for a minute. Okay, I'm going to put away these plates first. And you're probably going to have to do it 1 or 2 by 2, whatever. But just making the task smaller instead of trying to grab all of the dishes and they fall into the floor, taking a little bit more time. Also, I deal with foot drop, and this has been the bane of my existence. I mean, this is probably the most frustrating thing in the world. So when I get up in the morning, when I get out of bed, I have to take 5 seconds before taking the next step. Because if I don't, my equilibrium hasn't set yet, and then my foot will drag against the ground and I fall. And I've done it several times. And also make sure your floor is clear, because your foot can grip onto anything and that can really throw off your balance. So I would say slow down, hurry up and slow down, because you don't need to be in a rush. You'll get the task, things need to get done the time you get done.
Let's talk about sponsor Like-Minded. Like-Minded is a nonprofit membership program that helps you live your best post-stroke life. Like-Minded offers classes on everything from hand exercises to telling your story. The virtual classes are led by survivors, OTs, PTs, doctors, and more. They're held throughout the week, but if you can't attend one you want, that's okay, because members get access to the recorded version of the session so you can still catch up. If you have a specific question, reach out through the private text messaging group that's also a part of the program. Get the support you need and deserve to live your best post-stroke life. To find out if Like-Minded is right for you, visit strokecast.com/like-minded. Use promo code STROKECAST to save 20% off your first month. It turns out there's a lot of value in doing the numbers for science. Who knew? I mean, obviously not the COVID anti-vaxxers or COVIDiots, but that's a rant for another day. It may seem like the obvious response to the question of whether or not to close a hole in the heart is, OMG, of course, what are you waiting for? But as it turns out, it's not that simple. There's a lot more nuance to the question and whether or not the patient's going to get any benefit from it. And that's what the science tells us. Nearly 2 billion people on the planet have a hole in their heart. They have a PFO. And most of them don't have a problem with it. Any medical procedure, of course, is going to have risks. So you want to make sure that the advantage of the procedure outweighs the risk and the cost. And the data shows that in many cases, there is no advantage to closing the PFO surgically. And that's something we wouldn't know without looking at the data. One of the main things Dr. Thaler said we need to do to improve clinically is we need to improve the collection of data about individual patients' PFOs. In order for cardiologists and neurologists to make the best recommendation to the patient, they need precise information. Information they may not have asked for in the past, like just how floppy is that opening? And the technicians conducting those exams, those ultrasound exams and those bubble tests, need to be able to provide that information and know that they need to provide that information. And that's where this whole team comes together. I also found Dr. Thaler's discussion of the term CVA to be entertaining, especially considering how prominent it is in my own medical records, which also, by the way, describe me as pleasant, and I feel it's important to remind everyone of that. In other news, on March 1st of 2022, and if you're listening to this episode when it comes out, that's tomorrow, I'm moderating a panel for the Stroke Connection program of the International Stroke Conference. I'm pretty excited about this. I'll have more details in the show notes. If you'd like to attend the virtual panel, tickets are $10 through the American Heart Association. So check the show notes for more details. Session should be available for replay afterwards if you listen to this after March 1st. And of course, in sadder news, I'd be remiss if I didn't mention this. It's the news you all know. I'm recording this final section on February 27th. Putin's invasion of the Ukraine and slaughter of citizens is now well underway and has been for several days. As this unfolds, and looking at the future of where this is going to go and the threat this poses to the Ukraine, the countries bordering the Ukraine, the NATO allies, and the rest of the world. It really takes me back to growing up in the 80s with the constant threat of nuclear war hanging over us. I mean, we got a reprieve from that for the past 30 years, but I mean, we're right back there again. Life isn't something to pursue after recovery from stroke. Stroke recovery is something to do while you live your life. Pursue your adventures now, because our stroke experience is a reminder that all of this, everything we have, the good and the bad, it can end in a flash with no warning. The situation in the world today is a reminder that we're not done with dangerous stuff. The stroke doesn't confer any sort of immunity against trauma or threat. It just hopefully prepares us for when things go upside down. I'd also ask that you take a moment, wherever you are in the world, to say a prayer or share some positive thoughts or good vibes or whatever it is that you believe in and find comfort in, especially for all of the stroke survivors in the Ukraine and the neighboring countries. They've gone through a stroke only to now see this happen as invaders start to overrun the country. And don't wait. Live your life. Doing so is not only sort of the point of your life, but hey, may also help your recovery. So check out the show notes for more information about Dr. Thaler's work with PFOs and for information about the neurology exhibit at Tufts. Be sure to share this episode with someone you know by giving them the link strokecast.com/PFO. Subscribe to the Strokecast newsletter at strokecast.com/news. And of course, as always, don't get best. Get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.